morning. Up to now, you have heard O.P. Kapoor as a science physician, scientist if you want to call it. Today's lecture, I am going to explain to you that how general practice is a mixture of science and art of medicine. And today, in my lecture, I am not going to talk anything about science of medicine. Why? Because when you talk about headache, I don't know what is headache. I mean, the patient comes and tells me he has got headache, and I start fooling, I start teasing him. Where is the headache? Where is headache? Where? Here? Here? Here, headache. What I am trying to tell you is that what is headache? What is it felt? We don't know. We know nothing about headache. Please remember that. And please be frank with your patients. Your patients are like your friends, like your family members. Tell them, हमको कुछ, we know nothing about your headaches and all. Tell me, I'll try to help you. Headache patients can be helped. They cannot be investigated and cured. No. And here comes your art of medicine. So doctors who know the languages, who speak so well. Yeah, I'll give an example. See, 30 years back, I announced that I'm going to see only middle class patients. So in my last 30 years of practice, I have seen only middle class patients. And believe me, I've learned a lot. Middle class patients, low middle class, upper middle class. Of course, poor class patient I have off and on because my fees are so high. Don't see many, but I do see, not that I don't see. These patients are of two types. One who believe in God, one who don't believe in God. And I am telling you, if you want to be a very good general practitioner, you have to believe in God. Don't take the credit. I cured him. I gave him medicine, his headaches disappeared. No. You gave him medicines and God took away his headache. Every time I write a prescription, the same prescription for the same illness. When I sign, 1 second I tell God, please help me. Why? Because the same prescription does not help the another patient with the same diagnosis. Then what is allopathic medicine? What are you boasting of? We know what is head, we know what is brain, we know what is CT scan in the brain, MRI, EEG, we know. But what is headache? How is it produced? From where is it produced? We know nothing. Yes. One thing I know. What I know, I'll tell you. What is my observation? My observation is that those patients who believe in God firmly, only God I am saying, less incidence of headaches. You see all those gurus, spiritual people in the Himalayas and all that, I'm sure they don't know what is headache. Headache is a new thing with a new generation coming up, and with the tension increasing, with your mobiles increasing and your videos, headache is going to increase. Today, 30% patient in the population have got headache. 30%. And the same 30% have got headaches, hypertension also. They would like to associate. Doctor साहब ब्लड प्रेशर हुआ तब से मुझे हेडेक हो गया. No, both are common illnesses. What I am saying is, in my opinion, I've observed certain communities, for example, Jain community, alright, they are very God-loving, Whoever is their God. That's not the point. God living, incidence of headache is less. Muslims who do 3 times a day namaz, 5 times a day, not Juma namaz, not those type of Muslims. Those who do, incidence of headache is much less. And now what I find is, the new cults have started, and I have a large practice of, God has been kind to send me all type of patients of cults. I've got patients who are Radha Swamis. Radha Swami was like Osho, He has made a big town in Punjab. They're mad on him. Okay, agreed. And they'll say, I tell them, have chicken soup. No. I'm not supposed to have non-veg. Then I'll tell them, okay, have a little brandy for sleep at night. No, not allowed. I call Radha Swami, not allowed. And then when he takes out his purse, I find so much gutka in his pocket. Whole day he's taking gutka. Now, gutka taking is worse than alcohol, worse than non-veg food. Gutka produces, and the incidence of heart attacks in Radha Swami patients is same as non-Radha Swamis. But what I am trying to tell you is this. So there are cults, Brahma Kumari, no sex. No, I am trying to tell the patient, sex is good. Regular sex, make a time, say once a week or once in 2 weeks. Continue even after 60. You will remain healthy. No, I am Brahma Kumari. I can't have sex. See, the problem is, and today the cults are increasing. Today in India, the cult has become a business. So somebody said this, Sadhguru will say this, now the foreigners are coming. And they started their seminars. They're all money making. All are rich. To join a cult, you have to spend a lot of money and go, spend time. So you see, a lot of tension. If you want to only believe in God, and you think there is God, and the new cults have been telling the young generation there is no God. Opposite of what I am saying. If you think there is God, at home, wherever you are sitting, just pray. Remember God. Finish. You live this type of life, stay away from mobile and all that, your headaches will become, incidence will become much less. But what I have to now talk, because ultimately I am a scientist, that headache can be due to brain tumor, infection in the brain. Today the science of brain surgery has increased so much, you cannot believe it. You cannot believe it. They can operate without cutting. They can remove your things. Where are we? We have gone to a stage. So you don't want me to tell you about something about this type of headaches? Yes. So in my talk today, we'll start with what I would like you to know about headache. Mind you, my headache patients, all I do is to spend time with them, talk about everything, talk about cults, talk about God, talk about this. I don't believe in giving any special medicines and special investigations. So let us start with the first thing, acute headache.
Headache is a symptom of most of the fevers. Please remember that. But the important thing is the way each patient presents this symptom, the way each patient talks about this symptom, the way in which there are associated symptoms. That is very important. I'll give you an example. This patient says, he starts, क्या होता है? बुखार. He starts with fever as a first symptom. Then I ask him, और क्या होता है? Then she'll say, headache. She'll show headache. सिर भी दुखता है. और क्या होता है? कमर दुखता है. और क्या होता है? सब बदन दुखता है, कमजोरी. moment the patient talks about these generalized symptoms of ache, including headache, backache, that patient is got a viral fever as a cause of headache. Whether that virus is flu, whether that virus is dengue, or whether any virus, patient will have headache along with other symptoms of pain elsewhere. That headache then should not be given any importance. Now there is another patient who says that I get fever at night with chills, severe headache, sweating, lasts for a few hours. In the morning is alright. That is malaria. The malaria during the fever can cause severe headache. But it is only during the fever. After that there is no headache. Similarly, there is a condition called as acute sinusitis, overdiagnosed. All the headache patients they called a diagnosed as sinusitis. No. Sinusitis should be diagnosed when the patient complains of fever with cold, nose block, nose secretions, with bad throat, and the headache, which is not a real headache, frontal headache and maxillary headache. The headache is here and here. So therefore, it's not really headache pain over the sinuses. These are the frontal sinuses. These are the maxillary sinuses. And these patients, when you examine them, you press the sinuses like this. See, this is maxillary sinus. And ask, is this hurting? You go, yeah, hurting. Then press the maxillary sinus here. Is this hurting? Yes. Now, look at the nose. There are secretions there, yellow secretion, often yellow secretion. Throat is bad. This is acute sinusitis. Not the sinusitis on X-rays. X-rays show sinusitis in every patient. X-rays are very poor test to diagnose sinusitis. Now this patient has a headache, which is a frontal headache, due to acute sinusitis. The moment you are treating sinusitis, remember that most important treatment is the sprays, nasal sprays, nasal drops, and sting inhalation. Now, then we come to headache, which are serious headaches, and non-general practitioner should start practicing unless he knows about this. You should not practice. Dangerous. One day you will come into trouble because there are two important causes of these headaches. One is called meningitis, one is brain hemorrhage. Both the conditions are very dangerous. Meningitis is of two types. One is pyogenic meningitis, one is TB meningitis. Pyogenic meningitis, if you miss, the patient can die in 48 to 72 hours. So imagine one patient, always young patient, young girl, young man, and you miss the diagnosis of meningitis, and he dies in 2 to 3 days, you are going to lose your practice. Your name will be spoiled. Similarly, a patient 40, 50 years old, complains of headache, and you miss brain hemorrhage. That patient may recover for a few days, then he always get a second bleed within 10 to 15 days. In the second bleed, 40% chances of dying. 40%. Not only heart attack patient. And you can see we are now facing two dangerous conditions which should never be missed by any physician. How are we going to diagnose them? Let us start with first meningitis. Meningitis patient, you ask the patient, क्या होता है? He will start with headache, सिर दुखता है, मुझे जोर का सिर दुख रहा है कल से 2 दिन से, 1 day, 1.5 day, और क्या होता है? बुखार, high fever. So high fever, many young patients in young age with severe headache, और क्या होता है? कभी थोड़ा उल्टी के जैसा होता है, और क्या होता है? बस सिर दर्द, सिर जोर का दुखता है. That means his only complaint is headache and fever. No more body ache, no other symptoms. This is the patient when you suspect meningitis. And there are two types of meningitis. One is pathogenic meningitis. One is TB meningitis. Pathogenic meningitis can kill you in 3 days, 4 days. TB meningitis, if you miss the diagnosis, well, patient can die. More than that, if you go and die, he is left with hemiplegia, cerebral palsy, cranial paralysis, not a good life. So you can't really afford to miss it. So to diagnose meningitis, the only sign is called as neck stiffness, neck rigidity. So you put your hand on the head of the patient and you see the neck. You tell the patient, no, that I'm going to examine your neck. The moment you tell your patient you're examining the neck, the patient begins, I don't want the neck stiff. I want to see the stiffness of the neck, whether it is present as a sign. So what I will do is like this. देखो, ढीला करो, ढीला रखो. Now see, she is doing ढीला like this. Now I can see this. I can do this. Now, if this is present, most probably she has got no neck rigidity. If the patient cannot do this, cannot do more than this, there is neck rigidity. And the second thing then you do is you put your hand here and put your hand behind here and try to touch the chin here. Try to touch this chin here. If the patient can touch the chin here and you can do side to side, there is no meningitis. Finish. That means it's a beautiful sign to be elicited properly, slowly, sweetly, explaining to the patient, you relax. तुम ढीला रखो, तुम ये मत हिलाओ, तुम मुझे करने दो, like that. And then like that, ढीला. This is called neck rigidity. Finish. Now, suppose you want to see one more sign. Suppose one more sign is this, that in a sciatica patient, normally we do like this and see. दुखता है, we will find at this level patient will say, oh दुखता है, like that. If the leg is straight. In meningitis, all you do is like this. Now your flex, extend. दुखता है, patient can't do more than this. This becomes stiff. Can't do more than this. This is called chronic sign. I will say less important. Give more importance to neck rigidity. And normally you suspect meningitis. But investigation is only one second investigation. And if the GP is only about, they will talk about, they are very weak in the knowledge. about the investigation, and that is lumbar puncture. Lumbar puncture is removing the water from the back. That water comes from the brain. Once you remove the water from the back, you will see so often pus coming out, or cloudy cells are coming out. And when you examine that, full of germs. Lumbar puncture is the only method to exclude meningitis, not CT scan. And the GPs must learn it. Why do the GPs don't learn it? That is because of the pathologists. The pathologists all over India, they do hundreds of blood tests. They charge heavily, they make so much money. But in olden days, if I told them to do a swab of throat or nose, they say, send the patient to the main center. The technicians could not do. Now that the corona has come, they learn how to do a swab. Similarly, I have been telling the pathologists, that all pathologists must keep some anesthetist in their list. See, anesthetists are the very good people to put lumbar puncture and remove the fluid. And these anesthetists can be kept, can be called, can be paid. The patient will have to pay from his pocket. And the anesthetist gives the sample of the water to the pathologist who examines the patient, the fluid. The patient can rest for 1 to 2 hours there, and after 1 to 2 hours, the patient will go home and go home. If the CSF is clear, absolutely clear, meningitis is ruled out, finished. The GPs have no tension of meningitis. So, lumbar puncture has to be known by every doctor. It has to be explained to the patient that no test can diagnose this except removing the water from there. If you treat pathogenic meningitis within 24-48 hours by intravenous fluid, then of course you refer the patient to the hospital. You don't treat at home. The patient cannot be treated at home. If the patient is referred, nearly 100% will survive. Nobody will die. It's coming to TB meningitis. That is a little bit complicated. The TB meningitis patients may complain of mild headache, mild fever, going on for 1 week, 8 days, 10 days, you won't be thinking of typhoid. The only fever where the fever and that headache persists more than 1 week is typhoid. You may think of typhoid. But that patient might be having TB meningitis. And if you miss it, he could either die or he will recover with all this paralysis left over. So once more, any patient who complains like that, neck rigidity has to be looked for. And in those patients, when you look for neck rigidity, it may not be so much like in pathogenic meningitis. And even this, you may be able to do this much, may not be this much, but the patient may be able to do this much. So that means half little neck stiff, not full, not complete, which means minimal neck stiffness. Minimal neck stiffness is enough to ask for lumbar puncture. When you give a lumbar puncture, you can diagnose TB meningitis. This was about meningitis. Now the second condition, which is again very dangerous, and it's a hemorrhage. It's a subarachnoid hemorrhage. It's not the hemorrhage inside the brain. Inside the brain, hemorrhage is always very, very dangerous. There is no question over that. It will always lead to paralysis, one-sided. But this is outside the brain, this hemorrhage. But This can kill you. 40% chance of death when it occurs for the second time within few days. This has to be diagnosed by AGP. And how will you diagnose? The history will be like this. This patient was alright. Doctor said, it's now 1:30. Patient was already 1 o'clock. He was standing in the queue. He was going to the office. On the bus stop, he found there's something sudden bursting in the headache. Before they use the word thunderclap headache and whatnot. Thunder. The headache. So often patients use the word कि अंदर कुछ फट गया, ऐसा लगा फट गया, इतना से फट गया, and it happened within few seconds, 1 minute, 2 minutes, never more than 5 minutes. The cerebral hemorrhage onset is so sudden. Usually, it's not a very young man. Usually, it's 40, 50, 60, that age. Usually, the patient will get hypertension. But he is not taking medicine for that. And such a patient, one day, wherever he is there, develops a thunder headache, has bursting headache, like this, within few seconds. And within 5 minutes, he cannot move. He might vomit. And he is bursting. His headache is hitting himself. Severe headache, and he was taking me to the hospital. This is the patient where you suspect subarachnoid hemorrhage. And when this patient comes, you don't have to record the blood pressure or anything. One sign only to be looked for. Again, neck stiffness. Again, tell the patient, relax, look. If he can't move this, then again this. If he can't do this, he has got subarachnoid hemorrhage. CT scan, usually diagnosis. So CT scan of the brain can be done urgently. But the important thing is CT scan often does not diagnose subarachnoid hemorrhage. So the best investigation for that is again lumbar puncture. So once more, lumbar puncture to diagnose. And when you see the blood in the CSF, you have diagnosed subarachnoid hemorrhage. These patients in the past used to have 40% death rate. We used to operate on them. Operation was often successful, sometimes not successful, but they were left over after the operation with hemiplegia, paralysis, due to the operation. It was not a good operation. Now we have got interventional method of treating. Like you put a catheter or you put an angioplasty stent in the heart. Similarly, you put a coil in the brain and block that area which is bleeding. Finish. Costly, yes, but patient is cured. If you don't do it, headache will subside within 3-4 hours, 5 hours, but within next 2 weeks, the second attack of headache will come where there are 40% chances of dying. So, all the doctors should know what is lumbar puncture. It can be done from the back, patient sitting. It can be done from the back, patient lying down. Anesthetists are the best people who can do lumbar puncture. That much about the acute headaches. So headaches are very common, but more important for a GP is to diagnose acute headache. First headache in the lifetime, first time. Moment the headache becomes chronic headache. It's coming on for years together, months together. The diagnosis is often migraine or migraine with tension headache. Now, it's very easy diagnosis. That the longer the period, easier it is to diagnose. But history should be taken properly. When was the first attack of headache? The first attack of headache when the girl was in the college. She went for a picnic. She got a headache, vomited. That was migraine. That is the first time. The second might come after 5 years, 6 years, 10 years. So chronic headache is very easy to diagnose, but unfortunately there is no investigation to confirm. You get caught there. There is no test to diagnose migraine. That's very unfortunate. Like asthma, same story, like bronchial asthma. That you cannot diagnose this disease and show the patient that this is chronic headaches which are going on for 1 year, 2 years, 3 years, which come and go are migraine. Therefore, you have to have 2 instruments with you, all these headache patients. Number 1, you put light in the eye. Light reflex. Really speaking, it is done to see the pupils, unequal pupils in brain hemorrhage. Here you are not suspecting brain hemorrhage. Where brain hemorrhage will have hemiplegia. But this test is done in all the patients to impress the patient that you are looking at the eyes, through the eyes something else. So otherwise it doesn't help. Yes, migraine patients don't like light. Remember that. Photophobia. Migraine patients don't like light. Migraine patients don't like sound. Phenophobia. So otherwise this torch is not useful. The other useful instrument is this ophthalmoscope. And I have been telling you earlier that all GPs should learn that how to not to see the retina, which is very difficult. You only want to see the optic disc, and that disc can be learned very easily if you switch off all the lights, complete darkness. Complete darkness. You have complete darkness and then you see like this, and because the pupil has become now big, you can straight go on the optic disc and see. Normally optic disc should be clean. Moment it is not clean, it is blurred, that patient has got some intracranial pathology, tumor, meningitis, hemorrhage. But between you and me, I can tell you one thing. Please don't get nervous. Even if you know nothing about it, use it. Use it. Why? Because after you have used it in these migraine patients, you can convince them, I am looking at the brain, not the eye. And I have looked at your brain nerves. They are normal. There is no tumor. There is no meningitis. So this is migraine. So you see, indirectly they are convinced that you have done some test to diagnose migraine. Is there any value of nervous system examination in patients with meningitis and subarachnoid hemorrhage? All I can tell you is this: concentrate on the eyes. Concentrate on the eyes of the patient. Now here was a patient. His girl came to me for low fever of 10 days duration in the evenings, headaches. Imagine, she used to go to the school with all these symptoms. And when I examined her, she had a terminal rigidity, neck rigidity. Terminal neck rigidity. That's all. No other symptoms, no other signs. But when I saw her eyes, I thought she had a slight squint. Now squint is a normal condition, is even normal public use, not really neurological sign. I was not very sure that she has a slight squint. So I told her to move the eyes on the right side. Next slide please. So she moved the eyes on the right, and now I could see the squint. See, she could not move the eye there. This eye she moved here, this she could not move. That is all. That was the only finding. And we did a lumbar puncture. She had TB meningitis. She recovered completely. Completely. Absolutely no leftover damage. Another patient I will show you. This patient came, normally we call it third nerve paralysis. It's not uncommon in diabetic patients, especially diabetic patients. There are many causes, but I think in private practice, common cause is diabetes. What happens is, one eye closes. One eye closes. This is called third nerve paralysis. Quite common in diabetic patients. They recover. 3-4 months, they recover. But what I want to show you is, this is a complete third nerve paralysis. But the next slide shows you a partial ptosis, drooping of the eyelid, partial, not complete. This is normal eye, and this patient was a 60-year-old man, hypertension. He had severe bursting headache, and I saw this sign, and he had neck stiffness. The CSF was done, confirmed subarachnoid hemorrhage. He was sent to the hospital where the coiling was done, interventional procedure, recovered completely.
So that means our duty becomes more as a scientist in a patient having acute headache, not chronic headache. Chronic headache patient, you see, they go around homeopathic, Ayurvedic, naturopathic, because they're fed up of allopathic doctors. And we've got a CT scan now available. Now, once the CT scan of the brain is normal, any pathology in the brain can be ruled out, finished. So you see, the problem now is not with acute headache. Acute headache, if you learn neck stiffness, lumbar puncture, the value, your patient cannot die. Coming to chronic headaches, where the commonest cause is migraine. We don't know what is migraine. I think if you ask me why it comes, from where it comes, what does the patient, nothing is known. But one thing we know, when I started my practice 65 years back, I used to see migraine once a week, once in 2 weeks, patient. Today, every day, in the comorbidity, not as a presentation, I can get a history of migraine, 30% patients. That I know. It increased. And patients, because they are living with that for years together, they form their own impressions. You see, you should understand this. Understand the psychology of the patient. Talk to the patient like a friend and tell him, we know nothing about migraine. There is no test to confirm it, but we know this is migraine, but we don't know how to treat it, we don't know how to prevent it. Explain to him like a friend and give him a big lecture. God has kept you so healthy. Look, you are 35 years old or 45 years old. Look how healthy you are. You have a lovely heart, lovely lung, lovely liver. But God has given you one handicap. And you can't accept that. You don't believe in God. God gave you one handicap. You're calling it a disease and you're going around doctors and you want it to be cured. So the patient will then wait and he now wants to understand what is that word you use? Handicap. Yes. This is not a disease. This is a handicap. How does it disappear? For 1 year, 2 years, 3 years. How can a disease disappear? This is a handicap. So what is a handicap? So you should see this. See this? I'm wearing these glasses for last 65 years. 65 years. Day and the whole day. You understand? Will you like to do this? This is called handicap. God gave me handicap. See, God has to give you something. Remember that. When you live, when you die, what disease you get. So God has given you this handicap. And then even then he is not, convinced, and he, क्या डॉक्टर साहब क्या हैंडीकैप, क्या कुछ करो, means you want me to reach God and tell him I can do that. I have got the mobile number of his assistants. Some of them are very strong people. I'll ring up, I'll tell him your name and, so and so whoever has got a handicap, please get rid of it. I don't know. I don't promise. He might do it. But one thing I tell you, in the past, whenever I did it for my patients, you know what was the answer they gave? Yes, they will remove your handicap. But they will give you another type of handicap. So I said, for example, this patient, what do you want to give? I want to give him thick glasses, which he has to wear whole day, lifetime. Shall I accept it? Will you like that handicap? Oh, no. Oh, no. I'm happy. This is how the patient is taught to learn to live with that handicap. Doctors don't do this. That is the trouble. Doctors want to show their knowledge. Yes, I'll diagnose. Let me do some tests, blood test, this test, CT scan, X-ray scan, skull. Take this tablet. Then you take this tablet. No, why should you tell him? I don't understand. Migraine has been there for the last 100 years. In olden days, when the women used to get migraine in the family, so what they used to think? They used to think it is either acidity or gas from the bottom. Why? Why did they think like that? And what did they do? They will tell the daughter-in-law, they will go in the dark corner, no light, nothing, and put balm and tie a hanky, right? And press the head. And of course, within 20 minutes to half an hour, the headache used to disappear. And then what happened? Then the interesting thing, toward the end of the headache, that lady brought out, she had nausea, then she vomited, and she brought out what? Bile. No food. That is because migraine usually comes on empty stomach. If you have more empty stomach, more migraine attacks. So either she brings out that so everybody sees that, and all the family collects. क्या हुआ? They say, oh, पित्त निकला. And by the time the headache goes away with vomiting. The nausea and vomiting of migraine are peculiar. See, they are not from the stomach. They are not related to abdominal system. They are like myocardial infarction. A patient who has got hypertension, diabetes, family history of heart attack, smoking, diabetes, drinking, fat, no exercise. And at night he has a party, and when he comes and he gets a gas attack in the chest. Gas, because he has drunk so much whiskey, so much food he has taken. They want to diagnose gas. Why? Because he gets this, and then he sweats and vomits. They say this is gastro. No, these vomiting are reflex vomiting. They come from another organ, like headache vomiting. I told you in meningitis, headache vomiting in subarachnoid hemorrhage. The same thing. This vomiting and nausea, feeling of vomiting, is connected to the headache of migraine, and is notorious for that. If you have eaten any bad food and you get vomiting, etc., you don't never get a headache. No. So but the patients are convinced, because they think there is no doctor doesn't know any other cause. There are other patients in UP, MP, these states. They think the headache means gas. सिर में गैस आया जोर का और सिर फट रहा था डॉक्टर साहब, और पीछे डॉक्टर साहब बांधा, ये खाया गोलियां पीछे, नीचे से गैस निकला और सब ठीक हो गया. They are right. They are 100% right. Because when you get an attack of migraine, severe migraine, all your sphincters become closed. You can't pass gas. So, moment the sphincter, the headache goes, attack is going, like vomiting, the sphincter relaxes and they pass gas. So now they are convinced. This gas went into the head and caused headache. Everybody goes on giving his description and his cause according to him. Doctor, because you have said it, you don't know, no? You told him, I don't know, no. What is this migraine? We know nothing. So he is trying to teach you. Remember one thing. Doctors go on giving tablets. Take this, take that, take that, take that. Wrong. Why should you tell the patient what to take and all that? Patient will learn himself what tablet works on him. Whether it is paracetamol, whether it is aspirin, there is a combination of two, ibuprofen, let him take that. Why do you want to give your prescription to the patient and take this, take that? No. You have to tell the patient, you take whatever suits you. The only thing is, the mistake which is most important done by all migraine patients and the doctors who don't explain to them is migraine is a very funny condition. So the scientists have worked on it and they've done pictures all over the body, and they find that when migraine attack comes here, in the stomach is a vasoconstriction. The stomach vessel, what is that connection? I don't know. Nobody can explain. So which means what? Which means when you're getting migraine headache, you take a tablet, whatever tablet you take, it will not be absorbed because the stomach vessels are constricted. Then what? That means you should give injection. No? You can give per rectum. Rectal suppositories are very popular abroad. In India, people don't like it. I don't know why. I don't know why. That instead of taking by mouth, you put it in the rectum, and your headache will go. Otherwise, injection. If you take injection, again you go to doctor. Wrong. So now, let us start with this chronic migraine. That chronic migraine. The first slide. When you say chronic headaches, as I said, chronic headache is very easy to diagnose. And the longer the period of months, longer the period of years, more likely it is migraine. Finish. And most important, you take family history. Family history is rampant. You can't believe it. Especially in women. When a patient comes to me, female patient, you know what I do? I ask her, ठीक है, वो तो तुम्हारी माँ को भी होता है ना? She'll say, नहीं, मेरी माँ को नहीं होता है. अभी नहीं, जब भी वो जवान थी. See why? Because migraine, as you grow older, migraine becomes less and less and less. After 70, 80, hardly migraine disappears. So they don't. You are asking, they don't remember when they were small. And then some of them will say, yes, मैं छोटी थी, मैं माँ को देखती थी, वो सिर बांधती थी. See, that's a positive family history. That is positive family history. And then you ask her, तुम्हारी वो बहन, कितनी बहन? 3 बहन. बहनों में से किसी को नहीं, वो एक की शादी हो गई, एक को होता है, एक वो गोली खाती. See, that's called positive family history. Then you ask for mothers, मासी को, छोटी मासी को, बड़ी मासी को. Family history in migraine means 99.9% you are right. 99.9%. So important is the family history of migraine. And when you ask them, They come for headache. डॉक्टर साहब सिर दुख रहा है, सिर फट रहा है, ये देखो, ये यू आर आस्किंग, ये सिर दर्द की बीमारी कब से? नहीं अभी, ये 1-2 महीने से। वो पहले don't accept that 1 to 2 months. The period has to be longer. So you go on asking, नहीं पहले जब भी तुम कॉलेज में थी होता था, नहीं एक बार हुआ था, एक बार मैं गई थी बाहर पिकनिक के लिए, हुआ था, उल्टी हुई थी, बस। That was the first attack of migraine. So that means history is so long. Then what happened in between? Why was she all right? How do you explain by your science? Sorry, cannot explain. So I told you in the beginning only, I know nothing about migraine. I am giving you only art of medicine. I am teaching you today that how to hypnotize the patient, how to explain to the patient, how to take him into confidence, how to take her into confidence, how to teach her to live with that handicap. That glasses I am putting on 65, in the first 1 year I didn't want to put on glasses. Till I had to learn. God has given me this handicap. I have to put on glasses. And I am putting on for 70 years. The attacks disappeared because we call that word remission. See that word remission? Very important. Does TB meningitis have remission? No. TB meningitis, the patient can come even after 1 month. You can miss the diagnosis for 1 month if you don't do lumbar puncture. A little headache, little fever. But there is nothing like a remission. If you get a cancer without treatment, is there anything like remission? Tuberculosis, is there anything like remission? Cough will increase. This is one disease where there is remission. Everything becomes okay, you have no headache. So, when does it come again? Why does it come again? We don't know. But tension. She gets married. Now she's got tension. She's got a husband. She's got a mother-in-law, father-in-law. And then she produces one child. Look at her tension increasing. And then with the mobile here and there, whole day talking. So there are a lot of these things which ultimately increase the frequency of migraine. But I want to tell you one thing. If you can talk like this boldly, the patient, तुमको भगवान को याद नहीं करते? You don't believe in God? अरे भगवान ने तुमको सिर में अगर ट्यूमर देता ना तो तुम मर जाती 2 महीने में. See, some of the brain tumors, you can die in 2-3 months. So you have to tell the positive aspect. अरे भगवान ने तुमको अंदर तो ट्यूमर तो नहीं दिया ना, खाली माइग्रेन है, ठीक है, उसके साथ जीना सीख लो. But the doctors, GPs have got the tension, subconscious tension. That this patient has got headaches for the last 1.5 years. अरे कोई अंदर कुछ ट्यूमर होएगा तो this is doctor's tension. Yes, I agree with you. Okay. So when you say tumor in the brain tumors, yes, known. They can kill you in 2 months, no question. I had a very brain tumor, neurology surgeon, JJ Hospital, Ginde. I'm talking about 50 years back. He had a very large practice. He was well known in every house named Ginde. He was very fond of me. OP. He will come and sit with me, come and. So I used to ask him, sir, आज कितना patient देखा? So he'll say, 15-16 पेशेंट कल देखा. 15-16 पेशेंट सर, इतना आप ऑपरेशन करेंगे, कितना लाखों रुपया? नो, out of that 16, 13 were migraine patients in headache. Only 3 were SOL, space occupying regions. Imagine a surgeon who operates on the brain, he is trying to teach you physicians. that out of 16 patients, he saw 13 migraine. So he must have assured them, अंदर तुम कुछ नहीं है, ये मेरी बीमारी नहीं है, physician के पास जाओ. But what I want to tell the GPs to remember, when you say space occupying lesion, forget about the tumors. Tumor is bad luck. It is like an accident. You go and you get and die if you don't operate. If you don't operate. There are 3 conditions which occur like a tumor. One is subdural hematoma, one is cysticercosis, one is tuberculosis. And all GPs must know about these 3 conditions. 100%. 100%. Otherwise you will make a fool of yourself. You will go on telling the patient there is nothing. What is subdural hematoma? Subdural hematoma is a blood clot outside the brain, outside the meninges, under the dura, small clot. And it produces headache. More common in elderly people. The older you are, the more chances of subdural hematoma. If you are 70, 80, 90, first exclude subdural hematoma. You see, it's like this. Even 78 years old patient comes to you and says, Doctor, I've got a headache. For last 4-5 weeks have passed. आता है, जाता है, रात को आता है, सुबह आता है. डॉक्टर बोलता है ब्लड प्रेशर नॉर्मल है. Don't get caught in that patient. His age is against it. It's the first time in life he is having this type of headaches. I can tell you on a piece of paper, write down 99.9% will turn out to be subdural hematoma. You do a CT scan. CT scan can pick up most of them small blood clot, which can be sucked with a needle without operation. Don't miss subdural hematoma. It can dry up without injection also, really, and become alright. That's not the point. Point is, you diagnose this bleed in a patient, any patient who's got headaches for the first time, and funny headaches every day, every night. May not be severe. May not be severe headache. Not like migraine patient shouting and vomiting. No. Don't miss subdural hematoma. CT scan will diagnose 99% these patients. It can occur in 60, 50, little injury to the head. So when I say injury, somebody hits you or something. In old age, it is not. In old age, though, you are climbing the steps and that thing a little bit. Oh, that much is enough. We come to second condition, cysticercosis. In the past, we taught it wrongly. All medical students, all the textbooks wrote everything wrongly. That this occurs in people who eat pork, pig's meat, which is normally in India, it's only Christians. Muslims don't eat pig's meat. Some Hindus might eat in the hotels. It was thought it was due to pig's meat where there is this worm, cysticerci. These worms go into the brain and cause headaches. Now it has been shown in my practice, for example, last so many years, it's more common in Jain community who never eat non-veg food. It's more common in vegetarians, not non-vegetarians. Why? Because these people eat only those bhajis and ghas and all, these Jain people. Now when they are grown, the pigs around, when they pass stools, they get contaminated. In the stools they pass the ova of tapeworm. And these are the ova which go into the vegetables, and these vegetarians go in the stomach. From the stomach they go in the brain. So cysticercosis is a universal disease all over the world, whether vegetarian, non-vegetarian, anything. If you find a young or middle-aged patient and you are thinking of space occupying lesion, that is, he never had a migraine in the past, he never had remissions, for example, he never had family history. Your one diagnosis should be in your mind, cysticercosis. And what You get multiple in the brain, not one, maybe 4 or 5. When I started my practice, they used to do operation. Now they're not. What operation? Now you've got those albendazole 400 milligram tablet. One of the best drugs which allopathy can boast of. I'm telling you, one of the best drugs. Like aspirin, what you can boast of, You can boast of albendazole. 400 milligram, one tablet. One tablet you give, most of the worms are cured. With the round worm, thread worm, all worms. Now come to the tape worms. Even the tape worms. But you have to give a tablet 400 milligram twice a day for 1 week. That means how many tablets? 14 tablets. So when the patient goes to buy from the chemist, 14 गोली दो, he laughs and all that. कौन डॉक्टर, कोई पागल डॉक्टर है तुम्हारा? किसने बोला? एक गोली है ना? He doesn't know. You're going to treat cysticercosis. And second thing, the GP must know one thing. When you give that tablet, the patient might get fits when treatment is going on. So always cover them with steroids and anti-epileptics for 2-3 weeks. Always. Cysticercosis is a very common space-occupying lesion you see all over those cricket players and those football players and somebody else had cysticercosis of the brain. Now, third thing in our country, tuberculosis. See, unfortunately, the doctors, when they qualified 30 years back, 40 years back and all, they learned only pulmonary TB. Pulmonary TB. So much so that in our medical college, I used to take objection that they started MD TB in lung tuberculosis. MD. Lung. I said lung. For what? How lung tuberculosis? Suppose one of the common tuberculosis is glands in the mediastinum, called as mediastinal gland tuberculosis. That means that doctor will not diagnose that. He will only diagnose lung tuberculosis and become MD. Then they change. And they call them pulmonology and this and that. What I want to tell you is, tuberculosis can affect any organ in the body. Any organ. You tell me the name of any organ. Right from skin, to the bones, to the brain, to the uterus, to the breast, to the testicle, to the kidney, to the liver, bone. What are you talking? Any body, like brain. No, brain, I talk about TB meningitis. That is meningitis. Here I am talking about tuberculosis in the form of tuberculoma. Tumor, like tumor. Space occupying, it means you are thinking about tumor. So here the tumor is not tumor, but tuberculoma. So you are lucky it will respond to medical line of treatment. No operation. No operation. So I must say that if you are dealing with this migraine patient, if first you want to relieve your tension, and he has gone to many doctors and he has gone to specialists, he has gone to Ayurveda, homeopathy, first you must have a CT scan. If CT scan can exclude subdural hematoma, cysticercosis, tuberculosis and tumors, then your diagnosis is correct. It is migraine. And you also, tension goes on that he has got no other disease. Now, because we don't know what is the diagnosis or confirmatory test for migraine, the doctors go on taking advantage, and all specialty doctors want to catch them. Sinus headaches. More than 50% of these migraine patients in the past few years, they must have gone to ENT fellow. He must have said sinus. They use the word sinus. Anybody having watering of the nose and headache is sinus. No, watering of the nose is vasomotor rhinitis, allergic rhinitis, where this water which comes out from the nose is like water. It's like water. It comes out like tap also with sneezing. How can you call that as headache with that as sinusitis? I told you sometime back, even in acute sinusitis, in acute sinusitis, there should be purulent discharge of the nose block off and on, and then those headaches with tenderness. Very rare. All wrong diagnosis. Even in X-rays and all that, you get misguided. And I'm very sorry. You have to give them a support. And that knows, I'm sure this is not a sinusitis. Then somebody will say, he went for chashma, and the doctor says, you got chashma. And I put on chashma and all that headache. I was better for 1 or 2 months. Again headaches have appeared. No headaches are eye headaches, I can tell you that. If somebody in the child cannot see the board properly, he will go to an eye specialist, naturally. If somebody, they're watching movie, everybody can see the movie. This boy cannot see movie, then they'll go to eye chashma. Headache has nothing to do. Even a glaucoma, yes, it's an important cause of headache in elderly population. In glaucoma, and even that I would say is wrong. Why? Because when the patient gets a headache there in glaucoma, he gets orbital headache, not headache here, or headache around the orbit, severe, and the eye becomes red. The moment the eye becomes red, they'll go to eye surgeon, they'll not come to you. So forget about all this. Eyes can cause a headache even if he has got a number, etc. And then we come to blood pressure and headache. Oh, very difficult subject. Very difficult to convince you. Very difficult to convince the patient. I have no other method of convincing also, except talking. Blood pressure is very common in normal population. 30% patients have got hypertension. And with that hypertension you have to live lifelong. If you start at the age of 35, 40, so blood pressure pills you take till you die, 80, 90. Migraine is also a lifelong disease. 30% population has got, but it starts at younger age and it stops at older age. Older age means after 70, 80. Which means there are lot of patients you're going to see who have got migraine and the blood pressure is high. So, it is very difficult to convince the patient that this headache is not due to blood pressure. इसे नहीं, ज़्यादातर मेरी प्रेशर ऐसी होती, आज ये प्रेशर ज़्यादा हो गई इसलिए headache. No, that day's pressure must have gone up. Normally they don't record the blood pressure. That is because of some financial problem. Somebody on the mobile said something, pressure went up. He wants to blame that migraine came because of that tension. But he wants to blame the blood pressure. And I find it is very difficult to exclude 100% from the minds of patients and the GPs. And the GPs also. No, sir, blood pressure was high. That is because you GPs have not seen real blood pressure. You people are thoroughly spoiled GPs. When we people started our practice 65 years, 70 years back, the hypertension, what readings we used to see? 220 by 120, 230 by 130, 200 by 110. Nowadays, do you see those readings? Then we used to see malignant hypertension. Patient having headache, convulsion, fundus showing hemorrhage. That is gone. I have not seen one case in the last 30, 40 years. This is a new type of hypertension. What is the new type? You don't know, you got machine shows, machine. So this machine shows, this machine, watch shows that my blood pressure. And they go on reducing the level of what is hypertension. Used to be 160 by 90, then it became 150 by 90, then 140 by 85. Now 130 by 80. More than that is hypertension. I don't agree. I'm sorry. You have to convince the patient, and therefore, one thing I tell you that when I will come to that just now, when you want to prevent migraine, you want prevention attacks, very frequent attacks. I like to use beta blockers, propranolol, beta blocker. Propranolol 40 milligram 3 times a day. many blood pressures will come down. There are only few which will not come. Then you give calcium antagonist, then ARB or one of these AC inhibitors. That's not the point. Point is this Indiral, when you give this beta blocker, it also works on hypertension. Not only prevents the attacks of migraine, good for both. So I'm very happy about it. I'm very happy about that drug. But I don't believe that blood pressure causes headaches. It's the tension headaches because the blood pressure has gone up. Therefore you find it high. Similarly, cluster headache. I don't want to teach whenever there is a headache lecture in the books. Headache, the 2-3 pages given to cluster headaches. I don't understand. I can challenge you. You will not see one patient of cluster headaches in your lifetime. I can challenge you. See, because they occur in a different type of population. Cluster headaches, and I don't want to spend time on that. It's a waste of time. In fact, they are periorbital headaches. Periorbital headaches. And in glaucoma, I told you, elderly people, this may be young people, very young people, orbital against glaucoma, and in glaucoma the eye becomes red here. Very interesting. With severe headache, the eye becomes red, the eye starts watering, the nose starts watering. Eyes are watering, nose are watering, skin is watering, sweating. All sweat around it. It's a very severe headache like migraine. But if at all I want to, suppose by chance you do get a case where you think I can tell you, take help of this rescue course. The rescue course which I taught you in asthma is applicable in number of illnesses. Number of illnesses. There I told you 40 milligram daily for 5 days. You can stop suddenly. 40 milligram for 5 days. If patient still not better, reduce over the next few days, or another 5, 6, 7 days. You can, in a fat patient, little overweight, or otherwise, or you can use 60 milligram for 5 days, 7 days. These are called rescue courses. There is one condition which can even respond to that when it doesn't respond to anything else. You can. I don't want to waste my time on this cluster headaches. Similarly, temporal arthritis, big books on headaches and all. I don't want to waste your time. I can challenge you. You will never see one patient of temporal arthritis in your lifetime. Never. Never. Why? This is a very rare disease. And it occurs in elderly population. We have no elderly population in India. We want a young population in India. There people are there who see 70, 80, 90, 100. Those are the patients when they get severe temporal headache on the temporal arthritis artery, which is tender. I don't want to teach. I will not like you to spend 1 minute on it. But I am just saying, suppose by chance you see that patient. Suppose elderly fellow, temporal headache, all the investigation normal, only this ESR is high. Take the help of rescue course. Once more. Rescue course. You start 60 milligram daily. In 3-4 days the headache will disappear. Challenge. So you should have no tension. And don't remember it. Or I would say, if you are called to see some patient who is 75, 80 years old and डॉक्टर इधर दुखता है ये दुखता है और वो डॉक्टर ने ऐसा दबाया नस भी दुखती है, that means temporal arthritis thing. You think of what? Subdural hematoma. You will be right. Even if somebody has done a CT scan, repeat. That will be more likely in that patient than temporal arthritis. So there is no question of wasting time on this iatrogenic headaches. We used to teach all these drugs causing headaches. In my opinion, all this is not applicable now. See, in olden days there was no bypass surgery, no stents. All patients used to get nitrates. Heart patient. So 30% population on nitrates, naturally it will cause headaches. They get headaches. Nifedipine blood pressure is still being used. Somehow I don't find it so much headaches. But what is important is, I would like you to know what is this analgesic headaches. In a headache patient, if you are a good doctor, a good GP, spend time and try to diagnose analgesic headaches. My experience of Bahrain patient, do you know I became very popular in Arab countries. I am talking about 50 years back, when they had no money, no dollars. Bahrain Salmania Hospital, a teaching hospital. They used to call me to lecture there 2-3 times when the doctor became fond of me. And I got references of 2-3 female patients. What was the disease? Migraine. Severe migraine. So because they could not treat with all the drugs, go and see Kapoor in Bombay, maybe he can help you. And I had a standard protocol. My housemates knew in Jaslok, admit them in Jaslok Hospital, suite, first class room. Do a blood count, blood test, X-ray, CT scan, MRI. Don't give any drug. No drug for those headaches. And on the weekend, they admitted, when I went on Monday, by the time I went, I used to ask them, what are us, Kef? Asan. Asan means better. Without any drugs. Better. That is because they were analgesic headaches. You see, Bahrain is one of the only Arab country which is a European-like country, in the sense that the women are beautiful, fair and their features are like Indians, so they're very beautiful with makeup and all that, and they all work. They will not, no housewife in Bahrain. They all go to work and they look after the house, they look after children. So fast life, like European countries where migraine is rampant, severe migraine. But that is nothing. Bahrain has got one more important thing which the European hasn't got. Sunshine. Very hot sun, my God. And there is no public system there are no buses and all these things. So they have to either walk or taxi. So that is how these women get those headaches. And they used to get headaches and they would take pills. They'll take tablets. Argot at those times was very common. They would take argot and whatnot, and yet the headaches were not improving. Why? Because they were analgesic headaches. Headaches produced by painkillers. And of course, I don't have upper class practice now, but I remember when I used to have upper class practice, they'll call one doctor, second doctor, third doctor, take his medicine, and the migraine is increasing, not increasing, reducing, because it is due to the painkillers. So, this is worth knowing. So, migraine, when you teach, it's difficult to teach migraine, because migraine differs in upper class, in middle class, in poor class. You'll be surprised, there is no migraine in poor class, because they have no tension. The poor fellows are daily wages. They have to go in the morning to earn their bread. They have no tension, no mobile. They're small little maybe mobile. There is no migraine. Middle class, lower middle class and upper middle class. Severe tension. And upper class, so there is no question. Throbbing migraine they get. So family history I told you, very long history I told you, remission I told you, female is most common. And now I want to tell you one thing. After you heard my talk on subarachnoid hemorrhage. Subarachnoid hemorrhage is it's your bad luck. If you're a doctor and your patient gets, it's your bad luck. You see, the point is, many of us have got some moles on the skin. Some people have got moles here, moles there. Nothing. But many of us got moles in the brain. That's the trouble. It's like in the lungs. Some of you have got those bubbles. I'm physically bully. Nothing happens. But one day some can rupture and cause pneumothorax. Bad luck. So similarly, which moles will rupture, you don't know. Which moles will not rupture, you don't know. But you have heard about it, that there is a hemorrhage causes throbbing headache, and they give the different names and all that. Thunderous headache, thunder. And these migraine patients have been reading, and they know, and they start imagining that they may be having this hemorrhage, and doctor is missing it. Remember that the diagnosis to exclude is very easy. I told you in the first session of mine that migraine bleeding causing throbbing headache is instantaneous. There is no other word. In Hindi there is no very good word. In English there is a very good word, instantaneous. That means 1 second headache starts and all. And when within 5, 10, 20, 30, 60 seconds, finish, it's bursting headache. And you're discussing it with you're doing a differential diagnosis of it with an illness of migraine, where it is the opposite. Opposite. The blood build-up is the most important word if you want to learn migraine. Most important word. Migraine headache builds up. Please remember that the two illnesses in medicine. The good GP, you should know both, like myocardial infarction. Myocardial infarction pain builds up. He said, please remember that. He gets the attack at night. He thinks it's gas. He thinks it's gas. It becomes better. He vomits, he sweats. But then it again increases. By 3 o'clock in the morning, Abhi doctor ko bolao. He's building up. Migraine headache is exactly same. 100% same. So much so, believe me, the migraine patient can know that this morning, aaj hone wala hai. Aaj migraine aane wala hai. They all know. They hide it from themselves. They hide it from the doctor. Why? Doctor goli dega. etc. हमको गोली नहीं खाने का, आदत पड़ जाएगी. See, they don't want to take a tablet. They think this thing comes again and again, and one day they'll get addicted. That is the problem about migraine. And what they don't understand is that when the headache builds, so for example, early in the morning she gets up and she's doing a little thing starts. She thinks, chala jayega. Then on the breakfast table, a little more, garam doodh deo, garam coffee, chala jayega. By the time she runs to the office and all that, 11, 12 o'clock, headache become more. And by 12, throbbing headache. By 12 o'clock, throbbing. Oh no, I want a hemorrhage. Call the doctor. See, you didn't take the proper history. That the headache was not acute onset. It was not instantaneous onset. It was opposite. It started. So, and the poor patient doesn't know that if at that time in the morning she had swallowed the tablet, whatever suits her, whatever, headache would have subsided. Because by the time this headache starts too much, the stomach vessels are constricted, nothing is absorbed. So it will not work. It will not work. That poor patient needs to be given a lecture. Migraine means what? Lecture, friendly, talk, art of talking in his own language, Marathi, Gujarati, Hindi, whatever it is. Give examples. Talk about the handicap. And that other thing, that there are very few headaches where there will be either nausea or vomiting and vomiting. And both. Nausea is as important as vomiting in migraine. Please remember that. Some patients get only nausea, no vomiting. Matli hoti. It's a horrible symptom. You get restless. It doesn't come out, no? And some people get vomiting, nausea, some people get too much vomiting. So much I got people who vomit too much, I give them this Temporal MD tablet, which is actually for vertigo. Sublingual. Sublingual means you don't know absorption from here required. You absorb from here only. So there are some patients who have too much vomiting, I'll give even Cimetil MD, and so that, because from the stomach it will not be absorbed. And that phobia, photophobia, they don't want light, they don't want sound, they want to write down something. And there is everywhere so much light nowadays, everywhere so much sound. And then comes to the precipitating factors. Wrong. You think there are precipitating factors? Very little. Sunshine, yes. Holiday, yes. Sunshine, see, in Calcutta, for example, so much of migraine in Calcutta. So the women, they have got the colored umbrellas. They go around with umbrellas. They don't feel shy. You take colored umbrella in Bombay and see, crowds will collect. वो लड़की देखो और देखो, अब बारिश नहीं है और वो छाता लेके चल रही है. When the British people came here to India, what did they find? They found sun. And what happened with the sun? They started getting migraine attacks. So what did they do? They made hats. What is a hat? Have you ever seen a hat? Beautiful. Hat is beautiful, very light. It's very light, but it goes there. So no sunlight, no migraine. And the Indian people, what did they do? When they went, I had two patients, I'm talking about 40 years back, who used to manufacture hats, and they said, no clientage, nobody is coming in by. Ultimately, they had to close down. You don't have any shop in India which is making hats. Hats is one of the best treatment for migraine patient. Instead of putting on a cap, you put on a hat in the sun when you go in the sun. Second thing is this holiday. Very few people will know this. I can't explain it on my scientific knowledge. That migraine comes on holidays. That is why patient gets more worried. That is why patient gets more afraid. That's why patient gets more angry. The doctor says it is due to tension, it is due to office, I am relaxing Saturday, Sunday, I want nothing to do. And the headache, whole day I want headache. That is the beauty of migraine. Don't ask me why. I don't know the answers of all this. I don't know. But I know definitely that this lady who has got so much tension, she'll get a headache on Saturday, Sunday. Or when she goes out for holidays. Mahabaleshwar here and there. So this is a peculiarity of migraine. You have to know this and explain to the patient. So the relief of the attack is no problem. I don't understand why you people tell the patient, take this, take that. Nothing. You ask the patient, what gives you relief? Finish. And if that is what gives you relief, it could be anything acceptable. You should accept it. Please, humbly. Don't go on giving, because it's going to be a lifetime. It's a handicap which is going to remain for years and years. So you can give aspirin, paracetamol, ibuprofen, naproxen. Never use, according to me, never use triptans. Triptans are costly drugs in the market. Believe me, I don't use triptan because triptan is only for upper class society when they get an aura. When they get an aura and those patients nasal that too. Oral triptans don't work, they increase vomiting. Either injectable. I don't want to discuss. According to me, anything but not NSAID group of drugs. Why? Because NSAID group of drugs are notorious for ruining your kidneys. And this is a disease which is going to go on for years together. You can't take NSAID. Once in a way, yes, nothing wrong. Once in a way. But routinely, you should find some paracetamol which will safest drug. But you can take this also, nothing wrong. Important thing is not to take this. Important thing is when to take. I get a headache actually while telling this patient because they don't still understand. नहीं, but I tell them, no, सुबह उठेगा तुमको मालूम पड़ेगा. But डॉक्टर साहब वो टाइम पे क्यों लूँ? वो टाइम तो मुझे सिर दर्द नहीं है, वो जोर का नहीं, थोड़ा शुरू होता है, वो फिर लोगों को आदत पड़ जाएगी. तो ये मुझे आदत नहीं पड़ गई, चश्मे की मुझे आदत नहीं पड़ गई. Did I not get used to my handicap? You have to learn how to live with your handicap. Simple. When patients who get very frequent headaches, what is very frequent headache? Once a week, once in 2 weeks. This is very frequent. But if you get once a month, once in 2 months, no prevention drugs, nothing is required. You only know what suits you. Do that, or at home you tie handkerchief, lie down in a corner, no sound, no voice, it will go away. But if you want to give drugs, there are so many drugs. In all the books you find, believe me, they are not for your GPs. Don't use them. Anti-epileptic drugs, all the allopathic drugs have got side effects. Please remember that. So when you use a drug, only if it is once a week, twice a week, once in 2 weeks, and the patient is fed up, usko kamti karo. Then I told you propranolol, best drug. And I would always combine propranolol with amitriptyline. Amitriptyline is an old drug, maybe 100 years old. I tell you, it's such a beautiful drug. Such a beautiful drug. It works in so many conditions. And not those doses which they write in the books, 50 milligram, 100 milligram, 150 milligram. I'm talking about 10 to 20 milligram. Why? Amitriptyline? I think because of it works on the brain, it gives you nice, like we give in depression patient. So it looks after the tension portion. So educate the patient, explain to him handicap. There are some patients, you are a good family patient, you have been very nice to them, they listen to you, but even then, they got fed up, they went to Ayurvedic, then they went to homeopathic, then they went to nature, then they come back to you, कि डॉक्टर साहब सब ट्राई किया, अभी तो आप करो, आपके हाथ में जो करने बहुत रोज हर दूसरे दिन सिर दुखता है, such, and he has gone to headache specialist, taken medicine. Best nowadays is botulinum toxin in the head and neck. Beautiful. You botulinum inject here, 6 months, no headache, guarantee. The trouble is what? After 6 months, maybe you have to give again, so what? But the cost, 20,000-30,000 rupees, 20,000-30,000 rupees. So a patient can't afford it. Acupuncture. And believe me, acupuncture has been proved to be as effective as these things, and if it is cheaper, if you find it cheaper, you can try acupuncture, no problem at all. And then we come to tension headaches. There was a time I used to diagnose tension headache very frequently. Migraine patient I used to diagnose a tension headache. Why? Because it came with tension. वो ऐसा पैसा उसने चोरी किया हमारा, उसने इतना लॉस हो गया, वो बिल्डिंग गिर गया. So I used to think it is tension is producing headache. I used to diagnose tension. But over the years when I have seen migraine increasing, I find migraine is the commonest cause of headache precipitated by tension. With the result that in the last 5-10 years, I am seeing very few patients of tension headaches. Tension headache is very easy to diagnose. Why? Tension headache is not lightning, but under something is more headache. How migraine patients talk. It is only tightness. Here is your hand. You put your scalp and tight it. You get a pain, ache rather than pain. Comes here more in the evenings. There is a lot of overlap with migraine. Back of the head and neck is a common site for migraine also. Back of the head and neck is a very common site for migraine headache patient. I am reducing my diagnosis of tension headache day by day. Increasing the diagnosis of migraine. But what I do is, to such patients, when I think it's due to tension, there is no test, I give them this tablet Libotrip. I'm an old-fashioned doctor. Libotrip is still available in the market. Libotrip is a combination of Librium and Triptanol, Amitriptyline. So, Amitriptyline, which I told you for migraine, Librium is a tranquilizer. For anxiety and depression, if you treat the tension headaches, go away. You give Libotrip 3 times a day, later on twice a day, later on once a day, and the tension headache will go away. But if it is a very bad tension headache and combination with migraine, etc., bad cases, botulism toxin. Botulism toxin. Finish. I don't want to give you the more knowledge about migraine, which I don't know what it is. What is it, why it comes, why it goes. But that much about headache. Before I finish, I want to show you something that in all these lectures, monthly lectures, I want to start one more item, and that item is I want to improve your medical diagnosis by diagnosing on an online patient, video consultation, and I find video consultation increasing. Let's have the video, please. And
now, before I finish, I want to announce that from this time onwards, after every lecture, I'm going to spend 5 minutes on showing you something, and that is the science on general examination in a video meeting, online consultation. What I find is that online consultation is becoming very common, and in my opinion, is going to continue for another 1 or 2 years, and maybe later on even permanently for people who stay very far out of Bombay. They would possibly like to continue this video consultations. So I feel that I should prepare the general practitioners for better diagnosis if possible. Mind you, I have said it before, the diagnosis is mainly made 90% on history taking. If you take a proper history, for which video consultation is the best medium, you will get the diagnosis. But if you do a general examination, even on a video consultation, you will have additional 5 to 6% chances of making a better diagnosis. So from now onwards, after every lecture, I will be spending 5 minutes on showing you just one patient as a sample on which you can make a diagnosis on a video consultation. For example, today I am going to show you a very common condition, as common as asthma, as common as migraine, found in about 30% population. And these patients come for a simple symptom of what is called as ulcers in the mouth. For example, these are the ulcers on the mucous membrane. Next slide. These are the ulcers on the tongue. If you notice, the tongue coating is absolutely normal. But the ulcers there. Next, we have another patient who can come for ulcers in the upper lip. If you notice, these ulcers will never be on the gums. They will never be on the hard palate. These ulcers come for no reason at all. And doctors diagnose liver diseases, stomach diseases, acidity, etc., etc. So, you have to be very familiar with this condition, a very common condition, and remember that the patient health is very good, appetite is very good, weight is normal, no anemia, and if you think you are in real trouble, you want to be 100% sure of your diagnosis, a simple test of ESR. ESR is normal, your diagnosis is correct. We call them Ptosis ulcers, stress ulcers. We don't know why they come. We don't know why the frequency is increasing in the normal population. But one thing is definite, these ulcers will come and they disappear within 1 week. Exactly like common cold. These patients will take B complex, somebody will take Benuron, somebody will take something else, liver capsules. Whatever you take in 1 week, these ulcers will become normal. That's the beauty of these Ptosis ulcers. And you have to tell the patient frankly that these are due to modern stress. They will come, they will go. But suppose these ulcers must heal up within 7 to 8 days, maximum 10 days. Now suppose you have a patient with ulcers that are continuing more than 10 and you are sure this is only on the mucous membrane which is flexible, loose. These ulcers will never occur on the gums or the hard palate. So you are sure they are Ptosis ulcers. And they are not, most of them, when they come, what prescription will you give? Local application of steroid. Steroid gels are available. Steroid liquids are available. Apply them and instead of 1 week they might heal up in 5 days or 6 days. But within 8 to 10 days they should heal up. Suppose they don't heal up in 8 to 10 days. Now we have got a drug called colchicine. Colchicine which is used in gout. This colchicine, 1 tablet twice a day. If you give in these patients where the ulcers remain for 10-15 days or come very frequently, then the response is very good because this is a condition called as partial Behçet's, where colchicine works very, very beautifully. Only in patients where the ulcers last for very long and come very, very frequently, one more drug which you can give to these patients, and that is thalidomide. Thalidomide is a sedative. In the past, it was removed from the market because it should not be given to pregnant women. It can produce problems. But it has now come back and actually you thalidomide tablets if colchicine does not work. Thalidomide will work definitely and the ulcers will heal. So here is an example of a condition which you can diagnose online on video consultation, and from next time onwards I will be showing you one case of each illness which could be diagnosed on better or without any physical presence of the patient, which could be diagnosed on a video consultation. Thank you.